All right. Good evening, everyone. It's at least it's 6 o'clock here in San Antonio time. So that is the hour or on the hour. So we're getting ready to start this evening's online office hours, and I'll continue to admit people. But if you could, in the chat function, this is kind of a check for me to make sure you can hear me. If this is your first time participating or watching a live sessions of online office hours, go ahead and say first time, or if you've been before, maybe just say returning or good to be back. It'd be nice to see how many folks are first time online here tonight. All right. Looks like we have a good mix of folks. So before we get started here, we'll tell you a little bit about what to expect for those that are the first time. And you probably could go to the YouTube channel and see a lot of our other prior sessions too. But tonight's focus will be on the clinical practice guidelines for low back pain. And we'll walk through those. We'll have some quiz questions. Hopefully that will be engaging or challenging. And we'll always cover, the answers to those quiz questions, and hopefully save some time at the end for you to ask any other questions you might have that I could help out with tonight. Um, Now, I see that you've either come on your first time or you're returning, but now another question is when do you expect to take the national board examination? We've got one coming up here in April, maybe July, maybe into October. So yeah, just throw the month in there. All right, a lot of Aprils and Julys I'm seeing. There's an October, couple October dates. Heather's in July. Good to see you, Heather. All right. Well, excellent. You can continue to finish that up as I move on. So a little bit about myself. So my name is Dr. Brad Tragord, and I'm one of the authors or co-authors of one of the chapters, the musculoskeletal chapter, and the review and study guide. I also have the great opportunity to serve as the interim chair and program director here at UT Health in San Antonio, Texas. So that's my day job. I enjoy teaching the orthopedic content or our musculoskeletal disorders content. And prior to this role here that I've served for about 3 years now, I was in the military, so active duty Army officer for 22, almost 23 years. The tail end of that, I spent 4 years as the director of clinical education at the Army Baylor physical therapy program. I also taught the spine section or curriculum, if you will, there. So you can see my background listed there, but I do enjoy outpatient orthopedics. I specialize in manual and manipulative therapy. So I've got a fellowship training, and my Doctor of Science focus is in mechanisms, looking at patients responding to manual therapy. And on the far lower right, if you will, if you haven't been to San Antonio, I welcome you to not only our campus here, but the beautiful Riverwalk. And it's just getting to be time of year where that is a beautiful walk. And if you enjoy a beverage, maybe a margarita, that'd be a great place to enjoy that. All right, that's enough about me. Really, our objective for this evening is to review the low back pain clinical practice guidelines. Now, these are both from 2012, but also the update from 2021. That revision contains information related to interventions that really weren't covered as in depth in 2012, which would include things like dry needling, cognitive functional therapy, and pain neuroscience education. We'll primarily focus on the level 1 and 2, or the grade A and B evidence tonight. We'll point out a few other relevant key bits of information as it applies specifically for the national board exam, the national physical therapy exam. And so, a lot of times using evidence or more recent evidence can be confusing, because we should know that the board exam is based on textbooks, right? And the thing, though, is that a lot of our textbooks are incorporating evidence-based answers or evidence-based information that is found in our clinical practice guidelines. So just to reassure you, it is definitely worth spending some time diving in to these. So that's what we'll focus in on tonight. The Looking at the components of the National Physical Therapy exam, or if you were to open up the content outline, by this point, you should be aware of the big three: musculoskeletal, neuromuscular, and cardiopulmonary. You can see how those are broken out and how we would like to encourage you to spend a lot of your study time focused on these areas. But don't forget, there's other systems that include lymphatics, GI, GU, integumentary, endocrine, and those system interactions. Those uh, non-systems would include things like equipment, technology, safety, and related content there, like research, for example. Tonight we're focused on musculoskeletal, right? That's a large, big hitter, if you will, one of the big three, the biggest of the big three. And we'll talk specifically about physical therapy examination, those tests and measures and what we do hands-on, the evaluation and differential diagnosis, along with prognosis, looking at things on how we might be thinking or critically appraising, and particularly how we screen out for more serious concerning disorders or pathologies. And then, yeah, interventions too, right? I mean, that's going to be a key to this is recognizing evidence-based recommendation, use of interventions and different strategies there. So yeah, that's what we're going to look towards. You can look forward to about 44 to 54 questions moving forward. All right, but before we go through the practice guidelines, it's helpful for us to go ahead and look at some relevant information, regarding the lumbar spine. So that lumbar spine is made up of 5 vertebra and vertebral bodies, which include the L1 through L5 areas separated by their intervertebral discs. The articulations between 2 consecutive vertebral bodies form 3 joints. One between the 2 vertebral bodies, which is the disc. The 2 joints then are communicating, which are the articulations that make up the facet joints or the zygapophyseal joints. So those are really your 3 joints there. The open pack position or the resting position is mid-range between flexion and extension, while your closed pack position is much more in the extended spot. And I would encourage you for each joint region, whether it be the lumbar spine or other joints of the body, is to go back and look at those open and closed pack positions and relate how that might be useful in understanding interventions or different strategies of attacking or improving patient function. All right, the typical vertebra consists of the vertebral body, the pedicles, the lamina, which includes the superior and inferior articular processes or facets, the transverse process, and the spinous process. And hopefully you can see that on that picture on the right, and this is all review. One thing that is important is in injury or degeneration, certainly trauma to the motion segment could lead to spondylosis or spondylolysis, and potentially with any slippage, right, or instability, you could have spondylolisthesis. And so those are that forward displacement of one vertebral body on another. This is often from degenerative changes that occur. And so that will be helpful for us to consider going forward in the NPTE. Now, moving on, there is, we've got, go back one slide for you here. The lumbar spine, the nerve roots are important to consider here, and the potential for radiation of symptoms or radiating pain. So in the lumbar spine, the nerve roots exit through those relatively large intervertebral foramen, and each one is named for the vertebral body above it. So for example, the L4 nerve root on the right, it exits between the L4 and L5 vertebra. Because of the course of the nerve as it exits, the L4 disc only rarely compresses. It rarely compresses that L4 nerve root. Instead, highlighted in red there on the right, a disc herniation or bulge between L4 and 5 is more likely to compress the L5 nerve root. Only in more massive disc herniations or unusual, but potentially a lateral disc herniation would an L4, L5 disc herniation involve the L4 nerve root. So those are some considerations as you look down the extremity and expect things like dermatomal changes or sensation changes or potential weakness or myotomal changes on what nerve root is involved. All right. Now, as we head into away from the anatomy and kind of these functional biomechanics, we're going to move towards the clinical practice guideline. And a lot of times it's nice just to remind ourselves what is a clinical practice guideline. And the Institute of Medicine defines it as a systematically developed statement to assist us clinicians in our decision making about appropriate healthcare for specific clinical circumstances. So in this case, low back pain management guidelines. It's important to note that our guidelines are not meant to be prescriptive, but that they may be overly general at times for us, and we have to dive in deeper to the references that they might suggest. But there is a lot of value in staying consistent. And really, the purpose of our guidelines is to reduce practice variation across a profession. It can also help with lowering costs and improving overall healthcare outcomes. So there's an attempt to look at particular topic, identify relevant issues, review and synthesize the evidence around those issues, and then make these recommendations for us. So important to us tonight is that low back pain is the fifth most common reason that patients visit any healthcare provider. And it is really so common that upwards of 8 out of 10 people experience low back pain within their lifespan. Although the pain might be severe and your patients, and I'm sure those that have gone through clinical rotations at this point might have had these experiences where patients come in with severe, concerning low back pain. The truth is that most low back pain is not due to serious problems. The diagnosis and treatment approaches for most patients with low back pain is similar, and it can be reassuring to approach patients based on clinical practice guideline recommendations. Now, it is often categorized as at least acute, which is up to 6 weeks, subacute, which is that 6 to 12 week mark, or chronic, more than 12. It's important to note that when we look at the update or the revision to the guidelines, the authors suggest that acute low back pain is 6 weeks or less, and chronic is 6 weeks or greater. So that's kind of the operational definition that we will work with when we focus in on the 2021 guidelines. Okay, and tonight we're going to bounce back and forth between the 2012 guidelines and the new revision update. And all that is because we want to use the founding practice guidelines that is endorsed by the 2021 revision, because its purpose was to take us from start all the way to finish. And so there's really a pathway that's laid out from the guidelines for us, first with medical screening as the baseline determination of appropriateness for physical therapy. Does the patient belong in our clinic? Usually back pain is felt in the low back and buttock. Sometimes it can be involving the nerves and cause leg pain or numbness or tingling down that lower extremity. The CPG recommends that we classify conditions into subgroups, and that's through our examination and evaluation and clinical findings. It's the thinking about what exam findings that we conduct. Then it is important to determine the stage of the condition. Now, whether that's acute, subacute, or chronic. We'll also want to consider other factors such as biopsychosocial elements, tissue irritability, and this will help us approach the patient in terms of intervention and our dosage. And really, ultimately, it's how we direct our efforts towards evidence-based interventions that the guidelines want us to focus on. Okay, this figure here is from the Therapy Ed Review and Study Guide. And so if you haven't, had an opportunity to purchase that big book, I encourage you guys to do that. It's a great consolidated source to prepare for your studies, and also can help you in terms of, understanding what clinical practice guidelines exist out there and how you could use those in clinical practice as well. But first, we're going to focus in here on the differential diagnosis section. Direct pathoanatomic causes of mechanical low back pain is rarely identifiable, which is kind of a frustrating thing. There are numerous anatomical structures in the spine that can be sources of pain, like our facet joints, the vertebral bodies, the muscles, the ligaments, neural structures, the disc itself. And we should be testing for clinical findings in patients with low back pain to help determine the potential for the presence of serious pathology early in this process. So it can be a challenging to identify the source, but we should be able to highlight and target those things that are more concerning or serious. So what I'm going to do right now is if you've been to these sessions previously, we like to save sometimes we like to save our questions to the very end, but what I've done tonight is I'm going to ask you a question and I'm going to give you about a minute to read through and make a decision here. And so I'm going to populate a poll right now, and hopefully you can see that now that is populated, and going to give you about a minute to read through the question and, put in your answer. One would be A, two B, three C, or four would be D. So go ahead and populate that as you need, giving you about a minute here to read through that. Give you about 10 more seconds, 15 more seconds to put your answers in. All right, last few coming in. Excellent. All right, I'm going to go ahead and end that poll. And let's talk about this before we look at the results a little bit here. So you'll see that there's some key information that I've highlighted here. And so, we've got a 22-year-old patient, and anytime you see an age or a gender outlined in one of these test questions for your board exam, there's something that we're trying to tell you there, likely. So interesting, 22-year-old with low back pain. And then this alternating back pain has got something to do with the situation. Other key findings that we have is waking up during the second half of the night. We don't like night pain, and then pain that's improved with exercise, so improved with movement. And so let's look at what are the potential thoughts here. And it's spinal stenosis is the first opportunity there. Spinal stenosis, which is narrowing of the canal, if you will, often associated with degenerative changes or your older population. Central stenosis could lead to referred pain down both legs. There is another type of spinal stenosis, which would be like unilateral stenosis or foraminal stenosis that could impinge on a nerve root. But again, more commonly, that's happened in our older population. So let's move on and think about what other options we have. Osteomyelitis, an infection. If we don't have information that suggests a prior history of infection or disease going on, maybe that's an option for something that's serious with that night pain, but improved with exercise. Let's keep going here. Cauda equina. Hopefully, most of us are familiar with cauda equina syndrome. That is where we have the cauda equina being impinged and saddle numbness, or this numbness and tingling. Retention of urine or bowel and bladder dysfunction are common with that. We didn't see that in the test question itself. And as I share the results, and most of you got this, great job tonight, ankylosing spondylitis. This is one of those disease processes or inflammatory processes that we might see in our clinic, because early on, it presents in their 20s or even earlier. Sometimes in the second or third decade is when this first manifests as low back pain, and either people will present directly to physical therapists or be referred there. And so hopefully that's helpful to kind of get the mind thinking. Stop that and move on to this next. Yeah, so the correct answer there, just to be clear, was ankylosing spondylitis, with the key words that were highlighted leading to that. This figure that's outlined for you here should be helpful. It's from a McGee textbook that really outlines red flag signs and symptoms of a couple things. And I encourage everyone to become familiar with the constitutional symptoms listed on that far left column. Anything that might heighten our awareness of serious pathology. More specifically, we all need to be familiar on the lookout for two particular disorders, cauda equina and ankylosing spondylitis. So cauda equina is, as I mentioned briefly there, a rare but serious condition that requires immediate medical attention. And this is to prevent physical and neurological problems from progressing. So some potential causes would be a massive disc herniation, a spinal tumor, spinal infection, lumbar stenosis, potentially even a post-surgical complication. Common signs and symptoms, again, urinary retention being the most common symptom, with patients' bladder fills with urine, but they can't really experience or don't experience that sensation or urge to urinate. Also, just numbness or tingling in the saddle region or other bowel and bladder dysfunctions. Now, ankylosing spondylitis listed there, a rare type of arthritis that causes pain and stiffness. It's a lifelong condition. That bamboo spine, that is a classic descriptor of ankylosing spondylitis, but more at the tail end, as this condition progresses. Early on, these patients, present much like our regular mechanical low back pain. So we've got to be on the lookout for these key factors that are listed. Mechanical low back pain or leg pain really constitute 97% of low back pain presentations. So just to reassure you, what you see is going to be what belongs in our clinic. And though there is some lower percentage, maybe 1 or 1 to 2% of non-mechanical spine conditions and visceral disease, you might want to screen through these or be familiar with some of these other processes to a lesser degree in your preparations. So that's there for you to take a look at. Okay, so after considering differential diagnosis and ruling down serious pathology, helping reassure ourselves and the patient that they belong in our clinic, the clinical practice guideline focuses on examining and examination factors, right? What do we do? So sitting too much, being in poor physical condition, bending and lifting improperly are considered risk factors for low back pain. Stress and the lack of sleep can make pain worse. Older patients may feel more back pain due to weakened musculature or stiffening joints. So these are all potential considerations. We should use validated self-reported questionnaires, right? And these questionnaires are the top priority things that you may see that are related to the low back. So make sure you're familiar with this functional and pain assessment. But if you're not familiar with the Oswestry Disability Index, the patient-specific functional scale, or the global rating of change, I would just encourage you to pull them up and review these. Individual questions that are within these can be useful in understanding how you might approach low back pain. It's an important element of how we establish a baseline for our patients and can be useful in prognosis as well. For the ODI, it's commonly used in the clinic and in research. The minimal clinical important difference, it can depend on the patient population that's studied and what research design that you are looking at, but it's generally between 6 points or around 12%. There's 10 statements that are scored from 0 to 5, where ultimately 0 to 20% equates to minimal disability, while 80% and above really represents serious pathology, serious bedbound conditions, or potentially those that have exaggerated conditions or symptoms. All right, to facilitate patient management, the clinical practice guidelines and their authors recommend leveraging relevant exam findings to classify or to subgroup low back pain. So I'm sure most of you or many of you have been exposed to subgrouping low back pain because it is so difficult to find a pathoanatomical source. And so here we're going to review some of the ways to subgroup low back pain. All right. So listed are the classification groups that help us inform our practice. Low back pain with mobility impairments, whether that's the lumbar, thoracic, or sacroiliac. Low back pain that radiates to the lower extremity, or generalized low back pain. Those are really three major clusters, and they're outlined here for you. And listed within each box would be key physical examination components or findings. The authors here in the 21 update did not specifically align tests and measures with each classification, but these are pretty consistent with what we see in clinical practice. When evaluating a patient with low back pain, it's recommended to identify impairments. And so if you're not using an impairment-based approach, looking at the body function and establishing those baselines and prioritizing your impairments, the recommendation is to indeed do that. One thing of note is centralization. Straight leg raise and slump testing are more frequently used for patients with radiating pain. So if you have a case or a clinical situation where you have pain that's beyond the buttock and certainly past the knee, understanding centralization phenomenon, the straight leg raise and slump test is important. Okay. So although it primarily provides us with treatment-based updates, the guidelines provide these additional classification recommendations for acute low back pain. By the way, the table here would be for you to reference later. The interventions that we're going to talk about or the subgroups will be listed on the left in this table that was extracted from the clinical practice guidelines. And then the operational definition. So what really is or what are these different types of subgrouping or approaches to interventions? I'll let you reference that back. But again, when we look at acute low back pain and how you might categorize or subgroup folks, we still do consider this traditional treatment-based classification, which puts a patient into might they respond best to manipulation, to stabilization, specific exercise or these directional movements, or potentially traction on the far right. And what I've done for you here is outline at least some evidence-based examination factors that might help us suggest or place a patient into a manual therapy or manipulation group, right? Somebody that has hypomobility, low fear avoidance, somebody that does not have symptoms that radiate. Or maybe someone in that green category here, the stabilization, that they might benefit from more of an approach or at least a priority looking at strength, endurance, and motor control type focus. Those with a positive prone instability test or show these aberrant motions on examinations that might suggest this clinical instability. Individuals that might be younger or have straight leg raise or increased hamstring or flexibility. The people that might respond to directional movements or with directional movements demonstrate centralization phenomenon. That's individuals that have radiating pain might really have a good prognosis based on your movement screening that you do. And so being aware of those. And then finally, traction on the far right. Often a smaller subgroup than we once thought. Things like peripheralization with different movements, signs of nerve root compression might help you suggest treatment through a traction approach. All right, now we're going to shift a little bit towards the classification recommendations for chronic low back pain. So they are a little bit different now. So low back pain that is based on changes in symptom response to directional, specific, repeated lumbar spinal movements or sustained postures. Like these are things that are termed derangements or dysfunctions or postural syndromes. That process can be helpful and recommended for those with chronic low back pain. It also recommends that we consider classifying using methods to identify patients based on risk stratification, whether they're low, medium, or high risk, and potentially using a multidimensional screening tool. And finally, pathoanatomic or impairment-based examination findings can also help us to subgroup patients. All right, let's do another test question, break this up a little bit. So hopefully relevant to what we're just talking about. I'm going to relaunch a poll. And as you read this question, I'll give you about a minute. Read it and go ahead and populate your answer. Okay, I'm gonna give you about 10 more seconds to fill in your answers. So please populate something if you can over the next 5 or 10 seconds here. All right, I'm gonna go ahead and close this one off. All right, it looks like I'm gonna go ahead and end that poll right about now. And I'm gonna actually go ahead and share the results. You guys knocked this one out of the park. Great job. So this question, right? This question is asking us or giving us this patient presentation that has radiating pain, but then goes on to share that there's centralization occurring on repeated movement testing. So the assumption here is that we got to know what centralization is and the consequences of that, right? So number one, abolished back pain with new onset of lateral foot pain. Okay. So if most of you got this right, so you know that any onset of something that's distal is called peripheralization. So that's probably the opposite of what we want, even with improved back pain. So we'll scratch that one. Decreased back pain and leg pain. Okay, fair, but we talk about intensity. So this is one that I'm going to hold on to. That sounds pretty good. Decreased back pain and decreased pain intensity. Okay, number 3, increased back pain but abolished leg pain. Okay, so the symptom that was distal is now removed or gone. I like that one a lot. What might be confusing if you're not familiar would be, well, why would I have increased back pain? But right now, that one sounds like the best, and that's what most of you all selected. And yeah, number 4, no change in low back pain or leg pain. That's kind of a throwaway answer, frankly, there. So great job overall. Let's just take a quick look at this. Yeah, number 3 was the correct answer there. Mechanical diagnosis and therapy, or even just really the subset of this, which is mechanical test or repeated movement testing, is an important concept that we should be familiar with now at the entry level based on the guidelines. So, from the history, you should be learning about different positions or activities, establishing things like directional preferences. If patients are telling you they feel better when they're upright and moving, kind of in this extended lumbar posture, and worse when they're seated in this kind of static, flexed posture, we got to be able to pick up on that and connect it that maybe on the postural assessment or your movement exam, there might be some expected findings from that. But really on repeated movement testing, again, on the far right, you can see this person in standing or in a loaded position is bending forward to touch their toes. That might happen, 10 or 15 repetitions, potentially more. You would then reassess how their symptoms are or changing. Oh, and then you might do repeated extension standing, like at the upper right. The same thing, you could do flexion or knees to chest in an unloaded position or repeated extension and lying, a prone line, if you will, there. With this, right, the point or the concept here is that judgments of centralization require an accurate assessment of the patient's baseline symptoms followed by those particular movements. So we really have to establish how the patient feels and where they feel their symptoms then conduct repeated flexion or extension, typically. Our role is to then just observe and observe changes in the patient's baseline location of symptoms in response to those movements. Centralization occurs when the location, not just intensity here, of the patient's symptoms, such as pain or numbness, is perceived to be more proximal or more centralized towards the spine in response to those repeated movements or a sustained posture. Where peripheralization occurs when the location of the symptoms are perceived in a more distal location, outlined by the figure here. And again, you guys did a fantastic job, so I'll go ahead and stop with that one, and let's relaunch the poll as you look at the next question. Give you 1 minute. Maybe do about 10 or 15 more seconds to populate an answer, please. All right, I'll go ahead and stop the poll here. Last few seconds if you want to get an answer in. All right, I'm ending the poll. All right, before I share the results, let's work through this a little bit here. So I'll go ahead and click one time. This question again is focused on the clinical practice guidelines. I will preface this. This is not as much focused on maybe a question that you will necessarily see on the board exam, but I wanted to challenge you a little bit tonight on what this might be, this prognostic risk stratification. Again, this risk stratification is an evidence-based recommendation. And so someone comes in with low back pain, and what classification approach could we use? And we just went through some of them really briefly. And the treatment-based classification helps us categorize things into maybe that manual therapy responder, the responders to stabilization or motor control type programs or specific exercise or traction. That's less likely to be, risk stratification. The start back approach, which indeed, this is going to be the correct answer tonight. This is an evidence-based approach to match our treatments and the amount of multidisciplinary use. And so hopefully I'm going to introduce that to you here in a second. The pathoanatomic-based classification, again, is not necessarily a risk stratification. And although the oswestry is a great tool, outcome tool that we could use to look at prognosis, in itself has not been studied to actually stratify patients. So I gave you a little bit of a curveball there. Yeah, in fact, I did tell you how outcomes could be useful towards prognosis. So let's go through what this is getting after here a little bit. All right, so start back was the correct answer. There are new tools that look at asking specific questions to our patient population to help understand who may be at mild, right, medium, or more moderate or high risk. The Start Back tool is one of these commonly referenced risk stratification tools where a patient answers 9 questions. If the score is 3 or less, they're considered to be low risk. If the total is 4 or more, the patients are classified as either medium or high risk based on psychological screening. And so, and again, not to throw anyone off tonight, but I did want to, maybe challenge some of you that might not be familiar with this, and expose you some new bonus knowledge, if you will. All right. Here would be the matched interventions that this process, this risk stratification process would suggest. So low risk is really likely to improve almost on their own with some education. Medium risk would allow, focused effort in a tailored physical therapy approach, so like you and your patient one-on-one or in your clinic. And those at high risk are probably those that you need to incorporate a multidisciplinary approach and things like combined physical and mental approaches, cognitive, emotional treatments. We're not going to cover just a couple other key exam findings. These are probably bread and butter things that you're familiar with, but I do want to remind ourselves how important it is to conduct segmental mobility assessments of the spine. Your ability to identify hypomobility will be important in classifying these mobility impairments. The picture on the right outlines a clinician conducting segmental mobility assessments using a central posterior anterior accessory motion or glide. As you complete your mobility assessments, just a reminder, be sure to grade each vertebral segment as either normal, hypermobile, or hypomobile, kind of make that judgment. And of course, always inquire about pain provocation. Are you presented with pain here at this level? You can really do a nice job of localizing symptoms. I mentioned this earlier, but range of motion testing is an essential component of our examination and will be helpful in some of the diagnostic classifications, in particular with our generalized low back pain subgroup. If you're not already familiar with the term aberrant motions, these are any movement or movement pattern that deviate from quote unquote normal or our expected motions. These would be painful arc. So that's pain noted by the patient that increases throughout a portion of the total arc of movement. I think about the shoulder a lot of times when I think of painful arcs, but this happens in the spine as well. Gower's sign, that's that return to your upright position or your stance position using your hands or walking up. That's classically described for folks that have, or adolescents or kiddos that have muscular dystrophies. But again, chronic low back pain and the clinical instability can result in the Gower sign. So that's another thing to look out for. Instability catches, which is a sudden acceleration or stop in the movement pattern. Reversal or altered lumbopelvic rhythm can be observed when you do your forward bending or flexion assessment. And that's where that hip motion is greater than your lumbar spine motion during the first portion, maybe the first third of movement. And the lumbar spine motion might be greater than hip motion during that last movement. So just a reminder of aberrant. And then most folks at this point are familiar with the special tested measures. A unique one, I guess, here would be to bring up is the prone instability test, recommended to incorporate in those that may have general low back pain or may benefit from or help you identify those that might benefit from lumbar instability. The patient lying prone there on the right with legs resting on the ground, your clinician, you would put a P to A pressure on the spine, potentially reproducing symptoms. The patient would then lift up their legs off the floor just a few inches, and then you would reapply your posterior to anterior pressure. If the symptoms would be decreased, a theory you would have a positive test. It's been suggested that aberrant motions, maybe a positive prone instability test, coupled with some other factors, could lead you to prioritize motor control and stabilization training as an intervention. All right, now that we've discussed the major classification, exam and evaluation categories, let's move on to interventions. This is kind of the fun part. The authors of the CPG point out that clinicians should focus on impairments. That's the most important thing that is related to the activity limitation or the patient concern. And so prioritize your patient, their activity, their self-reported limitations or concerns, and you're gonna do good things. But also respect severity and irritability, their patient values, and other motivating factors. This is just a breakdown from the clinical practice guideline. As I mentioned, a variety of education interventions are recommended for acute low back pain, especially those focused on active lifestyle and remaining active. So these are education interventions that are listed here for you. In the acute stage, we need to really emphasize remaining active and really avoiding overprotection of the lumbar spine. Post-operatively, patients should be receiving education on spinal precautions, protocols from the surgeon, and things in terms of the expected outcomes or return to activity progressions outlined by the protocols. And from a chronic low back pain, we as PT should deliver pain neuroscience education alongside with our exercise and or manual therapy. Again, this is A-level evidence now. So the authors recommend to deliver standard education to chronic low back pain patients, again, in conjunction with an active treatment approach. Listed here are the level 1 and 2 recommendations for acute low back pain. So these are interventions. You can see manual therapy has historically been recommended for acute low back pain. There's potential to work on massage or soft tissue mobilization in the acute stage. Those with leg pain, so acute back pain with leg pain, exercise interventions to include trunk work and trunk stability and endurance activities, but also here's where you might see some repeated movements and that response to repeated movements in the acute stage. Listed here are your level 1 and 2 recommendations for chronic low back pain. So we went through some education recommendations, some education for acute, but now here are your priority for chronic low back pain. So for those determined to have movement control deficits, such as balance or proprioceptive impairments, targeted training to restore control of those functional movements is certainly warranted. In those with leg pain, you'll see a combination of manual therapy and exercise, but certainly your repeated movements. I think the theme here for me is that if you can find a way to centralize or find a directional preference for your patients based on the guidelines, that's a preferred approach. But then to be familiar with manual therapies and exercises and even neural mobilizations in those with leg pain could be beneficial. Again, movement control or this motor control impairment, as you find those with chronic low back pain, definitely would warrant specific trunk activation and control exercises. All right, you may have noticed that we did not discuss lumbar traction in the previous slides to much degree. The 2012 and 2021 revision provide a level D, which is really this conflicting evidence recommendation. So that said, there's potentially a subgroup of patients that benefit from traction, given their signs of nerve root compression, potentially the patient values. If you get things like a positive cross straight leg raise, that might heighten your potential to increase, your decision making to include traction. So I think the verdict is out. Also, the 2021 recommendations for dry needling for chronic low back pain is there, but it's currently at the level C or weak evidence. But we got to respect that that is a quickly evolving field as well. All right, so we went through the clinical practice guidelines tonight, went through a few questions. I got a few more for you here, and we'll have some time for questions. So let's go into a few more specific questions, and then we'll have a chance for some question and answer if you want. So I'm going to relaunch the poll here. Based on what we've discussed tonight, in the intervention section, give you about 45 to 60 seconds to populate an answer here for this one. Maybe about 15 more seconds here to populate an answer. Gonna go ahead and stop the poll in the next 3 seconds or so here. So if you want to throw an answer in there, go for it. All right, I'll go ahead and stop this here. Before we share the results, let's take a look at some keywords. We always want to encourage you as you read through the STEM or these questions that you are presented with on the board exam is to then kind of find those key themes or what the question is looking for. In this case, acute low back pain, and then mobility impairment. So I've tied it to the clinical practice guidelines, so we have some evidence-based answers here for you. In this case, lumbopelvic manipulation is the correct answer. And as I shared the results, indeed, the vast majority of you all did choose that. But let's go through a few of these answers. Not too many people selected transcutaneous electrical nerve stimulation or TENS. And there are purposes or times for that along with cryotherapy, but in terms of the guidelines, really didn't touch on that as a level A or B recommendation. But for the acute low back pain, yes, lumbar manual therapy or lumbopelvic manipulation would be recommended. The motor control, number 4, fair, that is a popular way and really appropriate way to probably layer on top of or in conjunction with manual therapy. So that is a fair response, but arguably the best choice or priority would be lumbopelvic manipulation. But going forward with chronic, or if you saw motor control or movement impairments, that could become then a better answer. But with the question stem asking or commenting mobility impairment, well, there you have it. All right, stop sharing that. We're going to do one more here. Relaunch this poll for you. Give you about a minute to answer this one. All right, I'll give you about 10 more seconds here to populate an answer. I'm going to go ahead and stop that. If you want to put an answer in, I'll give you about 3 seconds here. And I'll go ahead and end that poll. I'm just going to share the results. You guys did fantastic on this one. What are some keywords? Oops, let me go back up here. Yeah. Uh, a chronic low back pain. The stem here is asking us about chronic, which would be potentially different between acute and also post-operative low back pain in this situation. And you've designed an appropriate exercise program, so great job. But what is the best education intervention? Educational handouts, fair, but maybe let's continue on. Pain neuroscience education. Again, tonight's focus is on the clinical practice guidelines and the level 1 and 2 evidence. And indeed, that is the correct answer, which the majority of you selected. Back brace education probably, is one that we want to avoid using if so, we're using it for a very short period of time. If this happened to be post-operative back pain, arguably the protocol would require, at least acutely, the understanding of using back brace. But this was chronic low back pain. I like number 4 to discuss of the favorable natural history of low back pain, but that would probably be most appropriate for acute low back pain. And again, you guys did a fantastic job here. So let's move on. I think I do have one last question for you. This will be the last one of the night. So I'll relaunch this poll, give you about a minute. When you're ready, you can populate the answer. All right. Go ahead and maybe last 5 or 10 seconds here, closing out the poll. If you want to throw an answer in, go for it. All right, excellent job. Let's close that poll down. And wow, share the results. Great job again. Whether we just talked about it or whether you're tracking this clinical practice guidelines, the key question here is chronic low back pain. You did a great job prescribing or delivering patient education. Now you want to provide an active treatment plan. Guidance suggests trunk, muscle, and strengthening endurance type programs. So active approaches here might be a key word where arguably trunk muscle strengthening endurance is the only active approach, but patients could do neural mobilizations on their own. So that would be actively doing themselves. Those are recommendations there, but just not at the strength of trunk muscle strengthening endurance. And I put this question here, it's just as a reminder, is you all are aware of what we do as PTs. We use movement, and we use the fundamentals of movement and strengthening. And a lot of times the questions are not out there to trick you, but instead just to help reassure what you've learned in your programs or how you've studied on your own. Really, it is what it is. And so with that, I want to wish you all success. If you have a question, I would encourage you, we have probably time for 1 or 2 questions, and I can entertain those the best I can, whether it be from the chat function or online. But I understand we're about at the hour here. And so if you need to sign off, again, I really appreciate the time to spend with you tonight, and I wish you well. Please look forward to the next week as we continue the online office hours and preparation. We do this in the weeks leading up to, you're welcome, Nicole. We do these leading up to each board exam. So whether it be April, July, October, I encourage you to get back online and check those out. All right. So understand, one question I see here is, can you explain why the pain on the second half of the night is related to ankylosing spondylitis? I feel like it's more related to night pain. I don't have a great answer for that, except for that the stiffness, the inflammatory process of ankylosing spondylitis can settle into the spine. And so maybe through movement throughout the day, you can get to bed. These patients get to bed. They are able to settle down. But then just like anything else that provides inflammation or stiffness, it can settle and manifest in that prolonged position, right? So you think about people with arthritis or even rheumatoid arthritis, they wake up in the morning with this early morning stiffness, or pain. And a lot of times that works out through a period of time. This is a more progressive disease process where it might affect the later half of the night. So Emma, that's what I've got for you there. I hope that's helpful. I see another one. What's a random question? Nothing's random. What's the best sitting position for low back pain patients? Maybe I'm on a little bit of a limb here, but from what I know, there's no one best position except for moving out of positions and changing up your positions. I wouldn't discourage anyone from a posture standpoint. I don't have enough evidence that says posture relates to pain necessarily, but I do know that patients might associate a certain posture or prolonged position with pain. So encouraging them to set a timer on their watch or on their email if they're sitting for periods of time, just to move, to shift that position. There are some earlier mechanical studies that suggest that upright 90-90 position of the spine does increase the intradiscal pressures versus a more lean back position or a standing position. So potentially those will be options for you, Eden. Hopefully that helps. When does it perform? March Madness. All right. I like that term, that name. I don't know who you are, but I'm all in. I happen to pick North Carolina. Don't know why. It just kind of turned out that way. Hopefully my Baylor Bears get them. But, I don't know. I'm excited. But anyway, March Madness. When is it appropriate to perform straight leg raise versus cross straight leg? Huh, great job. Good question. My assessment, maybe my approach would be is if you come into the clinic with you're welcome, guys. If you come into the clinic with a radiating pain, certainly past the knee, that I have a suspicion of nerve root involvement, or nerve tension involvement, I'm going to do the straight leg raise. And what I'm going to probably do first is I'm going to do the straight leg raise on the opposite side, so I get a baseline of how this patient responds. So that's essentially the cross straight leg raise right there. Now, I might be cautious based on the severity of some symptoms where I might pick up a positive on the opposite or the uninvolved side. But what I'm trying to tell you is when I choose to do the straight leg raise, I'm going to do it on both sides. So I'm essentially performing the cross straight leg raise and the straight leg raise on my patients that have radiating pain. Because if that cross straight leg raise has been shown to be specific, hopefully that's an important term for you, diagnostically important to rule in discogenic nerve root related pain. But it also could be that if it reproduces radiating symptoms on the contralateral side, that it is suggestive of a poor prognosis. So I think it's important that we do the cross straight leg raise if it's positive, but in most cases, it's just really me assessing the opposite side, like I like to do with most of my special tests and measures. So then when I come to the involved side, where the patient has complained about symptoms, that they're familiar with what the procedure, where my hands are going to be placed, and what to expect. And that's probably more likely where I would pick up the straight leg raise, potentially add dorsiflexion, interrotation, adduction to sensitize the nervous system. March Madness, I hope that helps you there. And I hope I didn't miss any other questions tonight. That's all I've got. Lance, you're welcome. Good seeing you. And that's all I have tonight. If I'll stick around for just a few more moments, but otherwise, wish you well and good luck.